our next set of presentations, we hope to really get to the meat of the issue of management of benzodiazepines and medication-assisted treatment. We're going to discuss settings and coordination of care in a panel discussion format. So our presenters for the next section will be seated at a table up front, and we'll go ahead and get started. And following everyone's presentations, we'll have a pretty generous chunk of time for some questions and discussion among the presenters, as well as obviously from you all in the audience. So our next speaker, Dr. Laura McNicholas. Dr. McNicholas is a clinical associate professor of psychiatry at the University of Pennsylvania and the Philadelphia VA Medical Center. She'll be speaking on clinical management of the benzodiazepine-dependent patient. Dr. McNicholas?
Thank you. First of all, I have to say that everything that I have to say here today has nothing to do with VA policy, regulations, or anything else. This is mine, not theirs. And as you can see, somebody can't spell correctly because it's dependent with an E. When they asked me to be in this meeting, I gave them a couple of topics that I would like to talk on. This was not one of them because of the problems that I ran into with actually doing this presentation. So let's go ahead and get started. First, okay. All right, we'll do it this way. What I want to talk about is what we know and what we do. Notice the difference in font size, because what we know is much less than what we do. Some of the things that we do know are, there was actually a very nice paper on predictors of discontinuation of benzodiazepines. They were allocated, the subjects were allocated to either cognitive therapy or to treatment as usual, and that was primarily supportive therapy. And everybody got a scheduled benzo withdrawal of approximately 1/10 of the dose per week. The duration of the treatment depended on the initial dose, and the treatment of the control groups involved gradually tapering, whose rate the researchers did not define beforehand. Main outcome measure was attaining a state of abstinence or a decrease in the dosage during the study period, which was up to a year. So we're not talking about doing the 2-week detox here. The diagnoses were alcohol and other. Mood disorders were about 28%, lifetime occurrence of about 59%. Bipolar was 3 patients, so we're not going to go there. Anxiety disorders were what most patients complained about. Social phobia, panic disorder was 45%, and other was 26%. Personality disorders were not unknown. Any personality disorder was diagnosed in up to 64% of the patients who were abusing benzodiazepines. Most of them, as you can see, were in the cluster B issue, 26% there. Well, actually, there were quite a few in the cluster C too, but the issue really was that none of the patients with cluster B personality disorders were able to stop using benzos under either condition, treatment as usual, or increasing their treatment with cognitive behavioral therapy. Alcohol use disorder, benzo misuse, and other Axis 1 comorbidities did not explain the issue of the cluster B personality disorder. Neither did benzo dose nor the severity of benzo dependence. In addition, cluster B personality disorder was associated with dropping out of treatment. I think most of us would kind of already have known that, but it was, to me, really gratifying to see my clinical impressions justified by the data. When we're treating the patient who is narcissistic, antisocial, or borderline, which are the cluster Bs, we're all sitting there going, what do I do with this patient? Because a lot of them are abusing the benzos. They continually complain of both depression and anxiety disorders. And we're kind of, where do we go from here with them? There was another study that looked at success and failure rates of clonazepam detoxification and clonazepam maintenance of patients who abuse benzodiazepines. This was an Australian study. And what they looked at was success and failure. The top line is the detox, and the bottom set is the maintenance. Detox was remarkably unsuccessful in their hands. 13% of patients were successful at the end of a year. Failure was the hallmark, with 86% of the patients not achieving abstinence and maintaining it for any length of time within that year. I hate to say this, but success wasn't a whole lot better. Failure was 35% in the patients who they attempted to maintain on moderate doses of clonazepam. And so you still have patients, even if you try, and this is where we're really going to come into, is what we do. And unfortunately, it's pretty much on a case-by-case basis. You look at your patient and go, okay, do we try detox? Do we try maintenance? Do we try a combination of both? What do we do? And people try a variety of things. And by the way, there's absolutely no data on what works other than what doesn't work. Usually when we're thinking of detoxification, we're thinking of one of two options, either inpatient taper or outpatient taper. Inpatient is usually for patients with higher levels of dependence or with known problems for detoxification. How many people in this room have had patients who are attempting to, either with or without physician involvement, taper off of benzodiazepines and had adverse medical consequences? How many people in this room have had those patients have seizures occur during the detox? How many people have had patients who go into frank delirium? You can't try and detox that patient again outpatient. It's just too dangerous. A lot of patients, however, can be managed on an outpatient taper, or at least you can try to. One of the things that I frequently ask my patients, and my students and fellows always get a real kick out of sitting in on these conversations with me, because I will ask them what they're using. Oh, well, you know, I take a couple of Xanaxes twice a week or so. This is not the time for me to beat you up over your use. This is the time for you to be honest with me. When you use Xanax, what size tablet do you use? I like the big ones with the two, so you use the 2 milligram thing. Okay. How many of those do you take? You don't like the 1 or 2 a day answers, one or two a week answers. No, I don't like that one. I need to know what we're working with here. Are we working with 8 milligrams a day? Or are we working with 8 milligrams a week? And I've had patients who finally fess up to, it's in the 16 to 20 milligrams of Xanax range. It's like, I'm not even trying an outpatient taper on this guy. A lot of them are in the 4, 6, 8 milligram per day range. And depending on how compliant I think they may be and how motivated they are, then I may or may not consider, you know, an outpatient taper. When I'm looking at inpatient detoxification, this is prescribed benzos with by score or not. And as you can see, it really doesn't make any difference whether you go by scores or whether you don't go by scores. So it's symptom triggered or gradual taper. The data is pretty much the same. Kind of one of the things that most of us will go with is if the patient is on a short-acting benzo, something like Xanax. And frankly, that's the problem child in our methadone clinic over at the VA is Xanax. I usually switch them to a longer-acting one. They frequently look at me with the deer in headlights and go, you want me not to take the Xanax anymore? No, I want you not to take the Xanax anymore. I'm going to give you Klonopin and we will taper that down. What if I need it in the middle of the day? We're going to work on that. There's also data on using phenobarbital to taper a patient down, and I have done that. I have also had my patients come in very angry with me because their urine comes back positive for benzos 2 weeks into the taper, And I said, you're not supposed to be using the benzos anymore. You're covered on phenobarb. Well, if you'd just given me a benzo, you wouldn't know I was doing that, would you? Okay, this is not what we normally think of as a successful taper. So I usually, if I'm doing outpatient, and people that I've talked to, this is not a tenth of a dose decrease every other day or every day. Your patient's simply not going to tolerate on an outpatient basis. I usually try and decrease it about weekly. Some patients that I know have other diagnoses, PTSD, anxiety disorders, depression, I'll even drop that back to once every 2 weeks to try and taper the dose down. You need to monitor the patient with urines and benzo confirmations. And this is where the price tag comes in. Because fortunately, my clinical practice in the VA, I don't have to worry about that. Getting benzo confirmations is an expensive proposition, and I understand that. But if you are prescribing Klonopin, you really have to know that the patient is not supplementing with alprazolam if you're going to have a successful outpatient detoxification. And then you come to the question of, do you require psychotherapeutic support? I do. We actually came up with a support group that we started calling Quitting Benzos. We've since changed that to Coping Skills as the title because we thought that the other title was a little bit obvious. But it's CBT based, it's therapist run, and it's kind of a combination of the CBT and psychoeducation. For the patients, a lot of patients do not understand what the benzos do to them other than make them feel good. When you start talking to them about what it does to their sleep, what it does to their psychosocial functioning, what it does to their memories, they think, maybe this isn't the brightest notion for me to continue on this. But then they do need to learn different coping skills. Because one of the problems with the benzos is it really makes the patient's coping skills deteriorate. Let's face it, a lot of our patients didn't have good coping skills to begin with, or they wouldn't be in the position that they are. They need to seek us out. And now they're taking a medication that destroys their memory, so they can't remember what their coping skills were, so they really need to focus on learning new ones and how to deal with anxiety, how to deal with family problems, how to deal with their spouse being upset with them or their kids doing whatever. So the question mark is there for me to say, yes, I do it. Then you have the question of who do you place on maintenance therapy? For me, that's always a big sticky point. One of the things that I frequently end up doing is I will start a patient on a taper. Taper is not going to successfully because the patient is completely resistant to lowering the dose. They're not using anything else, and they're not asking for early refills. So I kind of, in those situations, sometimes decide to plateau with a maintenance dose for a while and then see if we can taper. I'm going to give you a clinical vignette here, and it is a patient that I actually saw yesterday. He came to our clinic from another clinic. He was on 180 milligrams of methadone, and from an outside provider, he was getting 4 milligrams a day of Xanax, of alprazolam. There were two major things that I didn't like. He was on alprazolam, and he was on 180 milligrams of methadone together. Didn't like that at all. So he has significant comorbidity. So he and I had a sit down, and after we got past the deer in headlights look from him, we decided that we would try and switch him over to clonazepam and then try a taper. It was going to be a very slow taper. And concomitantly, we would try and get his methadone dose down to what I considered a more therapeutically appropriate dose, particularly in the face of what would probably be a maintenance modality for his clonazepam. I saw him yesterday, and he is currently a year out on 110 milligrams of methadone and 2 milligrams a day of clonazepam, with not one urine positive for anything else. His family is so ecstatically happy, they can't see straight. He works every day. And sometimes, even though, yes, we would all like to say, None of my patients take anything other than methadone. We can't do it. How you choose that patient is really a case-by-case job. And the crucial thing is that you have to get the urines and you have to back up that when you are doing maintenance, you are actually doing maintenance. And the patient's not supplementing, the patient's not drinking, the patient's not doing anything else to address their sedative hypnotic issues. But they may or may not need the benzos for a longer period of time. Our goal is actually to get him down to 1 milligram of clonazepam a day. And he's finally come to the agreement that he may get there. It may take another year or so, but he may get there. So we're not talking short term here. Were other medications tried? What about SSRIs? What about NSR? What about paroxetine, fluoxetine, venlafaxine, whatever? Have you tried anything else? And then monitoring. And that, to me, is the crucial thing. What is the urine frequency? As I say, in the VA, I don't have some of the restrictions that publicly funded programs have. I can get a urine twice a week if I want to, and sometimes I do. If I'm doing an outpatient taper, I like to get twice a week urines. And if at all possible, if you can even get a dip twice a week. For one thing, and it's hilarious, one time I cut a patient back to once a week. He goes, I like the twice a week. I know I can't get over on you. And I said, why do you think I do twice a week? Because no, you can't get over if you're getting it twice a week. And so even if you just do a dip twice a week, sometimes the patient just needs that level of oversight and stability to help them do it. And then you have the frequency of urine confirmation, which we all know is an expensive proposition. But I think that at least having the knowledge that the clinician is going to know exactly what is in that urine. And it's truly amazing the number of our patients who do not think that we know how to read urine confirmation. I've had patients come in and go, I haven't taken anything. I said, then why is 7-hydroxyalprazolam in your urine? Huh? It doesn't come from clonazepam. You can tell that? Yeah, I can tell that. And then how long do you require psychotherapeutic support? Is it indefinitely? Is it an 8-week, 12-week time-limited structure? Again, that's going to be patient-specific. How do you do it? And then you come to the question of patient doesn't do it, does an inpatient, relapses immediately, does an outpatient, doesn't do well on that either, can't be maintained. Are you looking at a contract that the patient is really inappropriate for this level of care at this point in time? And does the patient need to go to be tapered off of everything and go to a residential program and see whether or not that's going to be helpful? A lot of times contracts work for patients. It gives them an incentive to clean up their act in a variety of ways and to stay in the program. And at other times it just makes them angry and they just say, I'm walking. So that's, again, where do you cut that line? And part of this is clinical judgment, part of it's going to be experience. And we all learn every day of our lives which way to treat each of our patients as we go forward. In summary, empirical knowledge is lacking. I really, really wish that I could have gotten up here and said, we got 3 great studies on how to manage benzodiazepine and opiate-dependent patients. As you can see, we don't have any. I really wish that somebody would fund one, but in the current situation, I'm not sure that's going to happen either. Clinical wisdom is to taper for any and all patients who can tolerate a taper. Maintenance for patients who can be maintained. And by that, I mean only on what is being prescribed. I, as a psychiatrist, am really, really adamant that I'm the only one who prescribes psychoactive medications for my patients. Don't tell me you're going to an outside psychiatrist and they're giving you X, Y, Z, and plus ABC. I don't want to hear it. I can manage your psychiatric medications. Monitoring is crucial. You're not going to get anywhere if you don't know what your patient is doing, because your patient is not going to be honest with you, at least in the beginning, in all probability. And then you have to look at what are your administrative decisions. Do you need to, I actually just determined that a patient was not appropriate for outpatient maintenance at this point in time. I had him hospitalized for 4.5 months with a prolonged delirium from a benzo detox from 20 milligrams a day of Xanax. And as soon as he got out, within 4 days, he was back on 10 milligrams a day. And it was just like, I can't do this. This isn't safe for you. It's not safe for me. It's not safe for the program. It's not safe for anybody. You need to come off of everything, go someplace structured, and see if you can get your head together long enough to be able to engage in treatment. And sometimes you just have to make that decision. And I think that I haven't even gotten the 1 minute. Do I have time for questions, or are we taking questions later?
Well, I had a stroke. My name is Joe Fritz. Ms. Wyman from the Golden Dementia Center here. I also write for school newspaper, and I also work in City Hall on the mayor's board. I've worked on the Edmondale, John Street, and McNicholas. I don't think they would have let me work there. Being on a methadone program, I am an epileptic. Now, because I took Dilantin and phenobarbital, the mixture of Dilantin, phenobarb, and methadone just didn't work for me. So my doctor prescribed Valium. I take 5 milligrams of Valium once a day. I take it at night. And I take it as my doctor prescribed it for me. Now, I know what it must seem like to you to have somebody standing up here in defense of taking a prescribed medication. But I'm 59. I shot dope when I was 14. I was in Cadenzia House when they first came to Philadelphia. So I've been through therapeutic communities. I've been in more groups than you got strands of hair on your head. I've been in marathons, mini-thons. My point is, addiction, in my opinion, is a very personal thing. You can't take a group of people and think that you're going to come up with an idea or a program of addiction that's going to work for everybody in that group. You're going to have one person that it'll work for. You'll have another person that it won't work for. I go to NA meetings. Because I'm on methadone, in NA, I'm treated like a second-class NA citizen. Even people in NA, some of them go to AA meetings because they feel at AA they get solutions rather than hearing war stories. I could care less about how you shot dope. I can tell you a thing or two. But unfortunately, these are some of the things that go on in treatment today. So really, treatment has to be a process done by the person that's addicted, the counselor, or the psychiatrist. Fortunately, I've got a great psychiatrist, Dr. Feinberg. He worked at Goldman. Then he went to 47th and Wyalusing. And now I think he's at Consortium. Anyway, everywhere he went, he took me with him. And I'm honored for him to have taken me with him because he knows me. I can talk to him gut level. I don't have to feel that I'm going to see my psychiatrist what lie am I going to tell him today? I can honestly talk to him from my heart, from my gut, and spill me. And the response I get back is always something that will help. Sometimes I talk too much. So right now I'm being told to be quiet.
But I think the point that you are making is that the decisions have to be based on the patient with whom we are working. Some patients will do well with getting off, and some patients will not. And we have to make that decision on a case-by-case basis that is patient-centered. All right.
Thank you, and thank you for your story.